Merriam-Webster defines personality as the set of emotional qualities, ways of behaving, etc., that makes a person different from other people. In other words, your personality defines who you are and how you relate to others. A personality disorder occurs when patient behavioral patterns and relationship patterns become maladaptive. Personality disorders affect the way a person perceives the environment and has an impact on the person's cognition, behavior, and interactions with others. Many who have a personality disorder have inadequate coping mechanisms and may have trouble dealing with everyday stresses. This disorder can create impairment in a person's everyday life. People with personality disorders present the most complex, difficult behavioral challenges for themselves and people around them. In the healthcare community, a difficult patient is almost always an individual with a personality disorder. PDs are among the most frequently treated disorders by psychiatrists and mental health practitioners, although the initial focus of treatment is usually a co-occurring symptom or disorder, such as anxiety disorder, depressive disorder, substance abuse, eating disorders, or even a medical condition. Personality disorders range from mild to severe based on their functionality. All people with personality disorders share common characteristics: inflexible and maladaptive responses to stress. Individuals have difficulty responding flexibly and adaptively to the environment and to the changing demands of life. They often are unable to cope with stress and react by using maladaptive behaviors, which exposes the disorder. Disability in work and personal relationships, which is generally more serious and pervasive than the similar disability found in other disorders. Besides having extensive disability in work and personal relationships, people with personality disorders often have difficulty with accurately perceiving and interpreting the world and others around them. They also can have inappropriate emotional responses to stress, happenings in the environment, or interpersonally. People with personality disorders often have a great deal of difficulty with impulse control as well. Individuals with personality disorders assume that everyone thinks and functions as they do. Therefore, within relationships, they do not view their behavior as a problem. They do not see a need to make changes or accommodate others. They believe that they are normal and that it's everyone else that has a problem. This thinking leads to problems with self-concept, relationships, and ability to function in society. Although some individuals with personality disorders may desire closer relationships with others, the following are some of the reasons personal and work relationships often fail for individuals with personality disorders: avoidance and fear of rejection, blurring of boundaries between the self and others so that closeness seems to lead to fusion, which may terrify both parties, insensitivity to the needs of others, demanding and fault-finding, inability to trust, lack of individual accountability, passive-aggressive traits, and tendency to evoke intense interpersonal conflict. People with personality disorders fail to see themselves objectively, and they lack the desire to alter aspects of their behavior to enrich or maintain important relationships. Relationships are often marked by intense emotional upheavals and hostility that lead to serious interpersonal conflict, and in some cases, violence. This could be self-violence or violence towards others. The capacity to get under the skin of others. With this, people with personality disorders often have an uncanny ability to merge personal boundaries with others, which has an intense and undesirable effect on others. Most people with personality disorders do suffer. Their relationships with others are problematic, and they rarely reach their potential. They are often socially isolated because of their rigidity, maladaptive coping skills, and control issues that complicate their interactions with society. These patients can act bizarre, anxious, withdrawn, manipulative, or violent, and their behaviors tend to alienate them from the population. Because they are unaware that their personalities cause problems, they often blame others for their difficulties or even deny that they have a problem. Personality disorders have historically been considered to be environmentally mediated. However, research results support a more dominant role of genetics. In a definitive study of 128 pairs of twins who were raised apart, Identical twins were found to have more similar personality traits than fraternal twins. Genetics seem to play a significant role in the development of schizotypal personality disorders, which is more common in families with a history of schizophrenia. Obsessive-compulsive personality disorder seems to have a genetic link as well. A strong genetic factor is found through family and adoption studies of the etiology of borderline and antisocial personality disorders. Disturbances in levels of the neurotransmitter serotonin have been linked with irritability, impulsivity, and hypersensitivity. Brain imaging studies suggest abnormalities in prefrontal, cortical striatal, and limbic networks that may be related to lower serotonin neurotransmission and behavioral disinhibition. That's in people with borderline and antisocial personality disorders. Excessive aggressive behaviors are triggered by a failure of cortical, like a top-down control of the limbic emotional system, which then triggers frustration, anger, or fear. Affective instability, seen in borderline personality disorder, is characterized by brief shifts of mood from depression to irritability to anxiety, all lasting up to a couple of hours in length. Affective instability is thought to be a result of excessive limbic reactivity in the GABAergic or glutamatergic cholinergic circuits. These shifts are dramatic and trigger impulsive aggression and self-destructive behavior, including drug and alcohol abuse, reckless driving, promiscuity, direct self-injurious actions, and as well as suicidal gestures or attempts. Children suffering from abuse or trauma, or children living in homes in which there is domestic abuse, divorce, separation, or parental absence, are at risk for development of personality disorders. Neglect seems to be particularly damaging. Childhood trauma may be a risk factor for any personality disorder in general, and for borderline and antisocial personalities in particular. Patients diagnosed with antisocial personality disorder often have a history including excessively harsh or erratic discipline, alcoholic parents, or an abusive or chaotic home life. This is particularly true for people with borderline personality disorder. There is consistent evidence that sexual abuse is a common risk factor for borderline personality, which also may entail significant parental conflict or loss. An early pioneer in the successful treatment of people with borderline personality disorder made the observation that those with the BPD frequently were raised in families in which they were subjected to constant belittling, devaluation, and validation. If the history of sexual abuse was before the age of 13, post-traumatic stress disorder may also present with borderline traits or diagnoses. Before concluding that a patient has a personality disorder, always consider his or her cultural, ethnic, and religious background. According to the DSM, the patient's signs and symptoms must deviate markedly from the expectations of his or her culture to qualify for the diagnosis of a personality disorder. For example, Asian and Northern European cultures place a high value on emotional restraint. Thus, stoic behavior in a patient of Japanese descent may be mistaken for avoidant personality disorder. On the other hand, people from Hispanic, Middle Eastern, and Mediterranean backgrounds tend to be more expressive. Keep that in mind before concluding that an Italian American patient has histrionic personality disorder. At the same time, avoid stereotyping patients. Individuals with the same culture or even within a particular family may vary widely in personality traits and emotional expression. Schizotypal personality disorder is marked by a pervasive pattern of social and interpersonal deficits, along with acute discomfort with others. People with this disorder have odd thought and behavior patterns. This disorder is a more advanced form of the schizoid disorder, but not as advanced as the diagnosis of schizophrenia. During times of extreme distress, patients also have cognitive or perceptual disturbances, although these psychotic symptoms aren't as fully developed as schizophrenia. Patients with schizotypal personality disorder commonly exhibit eccentric behaviors and have trouble concentrating for long periods. Their mannerisms and dress may be peculiar, and their speech may be unusual, overly elaborate, vague, metaphorical, and hard to follow. In the DSM, schizotypal disorder is identified as both a personality disorder and the first of the schizophrenia spectrum disorders, which are in general listed from least to most severe. The patients have magical thinking, strange fantasies, odd beliefs, unusual perceptions, and bodily illusions, social isolation, and paranoid ideas. However, unlike patients with schizophrenia, people with schizotypal personality disorder are not psychotic. A major difference between this disorder and schizophrenia is that people with schizotypal personality disorder can be made aware of their misinterpretations of reality, and as far as they have a far stronger grip on their delusions versus reality. The highlight of antisocial personality disorder is chronic antisocial behavior that violates others' rights or generally accepted social norms. This disorder predisposes a person toward criminal behavior. This pattern of behavior has been referred to as psychopathy or sociopathy. Other features of this disorder include impulsivity, egocentricity, disregard for the truth, and aggression. The antisocial person can't tolerate boredom and frustration. They are reckless, irritable, and unable to maintain consistent, responsible functioning at work, school, or as a parent. They lack remorse and exhibit few, if any, feelings. Although individuals with antisocial personality disorder are the most common among people who get into trouble with the law, antisocial personality disorder also occurs in milder forms. Examples include the spouse who continually cheats and the con artist who scams others out of money. Genetic and biological factors may influence the development of antisocial behavior. Biological factors include poor serotonin regulation and low dopamine level, which can affect impulse control and contribute to aggressive behavior. Also, reduced autonomic activity and developmental or acquired abnormalities in the prefrontal brain systems could account for impulsive behavior with aggressive tendency and emotional response. The essential feature of borderline personality disorder is a pervasive pattern of instability of interpersonal relationships, self-image, and affects and marked impulsivity that begins by early adulthood. Although people with this disorder may experience it in various ways, most find it hard to distinguish reality from their own misperceptions of the world. Their emotions overwhelm their cognitive functioning, creating many conflicts with others. Alternating extremes of anger, anxiety, depression, and emptiness are common in patients with borderline personality disorder. However, intense bouts of these emotions typically last only hours or at most a day. Distortions in cognition and sense of self can lead to frequent changes in long-term goals, jobs and career plans, friendships, values, and even gender identity. The patient may see himself or herself as fundamentally bad or unworthy. The patient may feel misunderstood, mistreated, bored, and empty, with little idea of who he or she really is as a person. People with borderline personality disorder tend to act impulsively without considering the consequences. Impulsive behaviors may include promiscuity, substance abuse, and eating or spending binges. Outbursts of intense anger may lead to violence, which are easily triggered when others criticize or thwart their impulsive acts. Some are brief, psychotic episodes. People with borderline personality tend to have intense and stormy relationships, alternating between black and white views of others. Their perceptions of family and friends may shift from great admiration to anger or dislike. Splitting is a tendency to view others around you as either heroes or villains. This is a defense mechanism meant to protect the person dealing from the situation, with perception of dangerous anxiety and intense effects. However, instead of offering real protection, splitting leads to destructive behavior and turmoil. Narcissistic personality disorder is a maladaptive social response characterized by a person's grandiose sense of personal achievements. The hallmarks of narcissistic personality disorder are self-centeredness, self-absorption, and an inability to empathize with the effects of one's behavior on others. A person with this disorder takes advantage of people, using them without regard for their feelings. They have an inflated sense of self and an intense need for admiration. The narcissist tries to maintain an image of perfection and invincibility to prevent others from discovering their weaknesses and imperfections. However, beneath the image are insecure individuals with low self-esteem. The narcissists expect to be recognized as a superior. Preoccupied with fantasies of brilliance and unlimited success or power, they believe that they are special and entitled to favored treatment. Their demeanor is arrogant and haughty, and their sense of entitlement is striking. This is the grandiosity. They expect others to comply with their wishes automatically and believe they should associate only with other special or high-status people. Many narcissists are driven and achievement-oriented. The narcissist's illusion of greatness may be shattered by a threat to their ego from either a physical illness, loss of a job, loss of a relationship, feelings of emptiness and depression despite material wealth and success. Such threats trigger panic. They feel their world is falling apart and their lives are unraveling. The exact cause of narcissistic personality disorder is unknown. One psychodynamic theory proposes that it arises when a child's basic needs go unmet. Their relationships are shallow and superficial and based on what the other person can do for them. Common characteristics of a narcissistic person are manipulation, the use of the defense mechanism splitting, tantrums, and arrogance with sadistic and often paranoid tendencies. The diagnosis of narcissistic personality is often associated with anorexia nervosa and substance abuse disorders, one of those being cocaine as the highest on the list. Avoidant personality disorder is marked by feelings of inadequacy, extreme social anxiety, social withdrawal, and hypersensitivity to the opinions of others. People with this disorder have low self-esteem and poor self-confidence. They dwell on the negative and have difficulty viewing situations and interactions objectively. To rationalize their avoidance of new situations, they exaggerate the potential difficulties involved. They may create fantasy worlds to substitute for a real one. The avoidant person yearns for social interaction, but the fear of being rejected or embarrassed in front of others is a daily obstacle. In fact, many times they're not willing to enter their social relationships without the assurance of uncritical acceptance. They even seek out jobs that require little contact with others. As with most personality disorders, there is no clear cause of avoidant personality disorder. The disorder most likely results from a combination of genetic, biological, and environmental factors. The primary psychosocial cause seems to center on parental rejection and the feelings of abandonment as a child. These feelings may develop into a low self-worth, and because of past abandonment, the world is viewed as dangerous. Obsessive-compulsive personality disorder is marked by a desire for perfection and order at the expense of openness, flexibility, and efficiency. People with obsessive-compulsive personality are preoccupied with orderliness, control, neatness, and the achievement of perfection. The person with this disorder sees the world as black and white. Along with the perfectionism comes relentlessness, anxiety about not getting things perfect. The patient with obsessive-compulsive disorder places a great deal of pressure on himself or herself and those around them. Mistakes are viewed as unacceptable, and the patient with this disorder may have a constant sense of righteousness or indignation and feel anger and contempt for anyone who disagrees with them. They also have difficulty incorporating new ideas or viewpoints. This is known as rigid perfectionism. Patients with this disorder view their methods as the only right way. All other ways are wrong according to their view. Their inflexibility extends to interpersonal relationships as well as daily routines. A lifelong pattern of rigid thinking may lead to poor social skills. Those with OCD have an overwhelming need to control the environment. They may force themselves and others to follow rigid moral principle and conform to extremely high standards of performance. Conscientious, scrupulous, and inflexible about morality, ethics, value, they insist on literal compliance with authority and rules. Paranoid personality disorder is marked by a distrust of people and a constant, unwarranted suspicion that others have sinister motives. Patients with this disorder place excessive trust in their own knowledge and abilities. They search for hidden meanings and hostile intentions in everything that others say and do. The paranoid personality is quick to challenge the loyalties of friends and loved ones. Many patients with this disorder seem cold and distant. They shift blame from others and carry long grudges. Because they tend to drive people away, they have few friends, which only bolsters their suspicions of a conspiracy against them. The specific cause of paranoid personality disorder is unknown. Its higher incidence in families with a schizophrenic member suggests a possible genetic influence. As children, these individuals are prone to temper outbursts and can be difficult to manage. Many times they are perceived as odd by other children and may be teased as a result. Besides distrust of others and their motives, other signs include refusal to confide in others, hypersensitivity, hypervigilance, need to be in control, self-righteousness, detachment, and social isolation, along with poor self-image, anger, jealousy, and envy. One of the big ones is a lack of support systems, among others. The hallmarks of schizoid personality disorder are detachment, social withdrawal, indifference to others' feelings, and a restricted emotional range in interpersonal settings. People with this disorder are commonly described as loners, with solitary interests and occupations, and no close friends. Typically, they maintain a social distance even from family members and seem unconcerned about others' praise or criticism. Most people with this disorder function adequately in everyday life but don't develop many meaningful relationships. Although they fare poorly in groups, they may excel in positions where they have minimal contact with others. As with many other personality disorders, the exact cause of schizoid personality disorder is unknown. Some researchers think it may be inherited. Other possible causes may include a sustained history of isolation during infancy and childhood, cold or grossly deficient parenting, or parental modeling of interpersonal withdrawal, indifference, and detachment. The assessment of a patient with schizoid personality disorder may reveal emotional detachment, inability to experience pleasure, lack of strong emotions, and little observable change in mood, shyness, distrust, and discomfort of intimacy. Histrionic personality disorder is characterized by a pattern of emotionally driven behaviors and overt attention seeking. People with this disorder are drawn to momentary excitements and fleeting adventures. Those with histrionic disorder can be charming, dramatic, and expressive. However, they are also easily hurt, vain, demanding, capricious, excitable, self-indulgent, and inconsiderate. The words and feelings they express seem shallow and stimulated, not real or deep. As a result, they often they come across to people as manipulative and phony. Despite their emotional responsiveness, their emotions may shift instantly from rage to friendliness. Their style of speech is excessively impressionistic, if not downright theatrical, and their gestures are exaggerated. They use grandiose language to describe everyday events and value words more for their emotional content than their factual accuracy. People with histrionic personality disorder need to be the center of attention at all times. They place great emphasis on physical appearance, often dressing provocatively and behaving seductively. Consumed with superficial things, they devote little time or attention to their actual internal lives. People with histrionic personality disorder may exaggerate their illnesses to gain attention, interrupt others so that they can dominate the conversation, and seek constant praise. They exaggerate friendships and relationships, believing that everyone loves them. They consider friendships and relationships to be far more intimate than they really are. Dependent personality disorder is characterized by an extreme need to be taken care of, which leads to submissive, clinging behavior and fear of separation or rejection. People with this disorder let others make important decisions for them and have a strong need for constant reassurance and support. To elicit caregiving, they engage in dependent behavior. Feeling helpless and incompetent, they comply passively and transfer responsibility to others. In fact, they seek others to dominate and protect them. Some stay in abusive relationships and are willing to tolerate mistreatment. When the breakup of a romantic relationship is imminent, individuals with dependent personality may become suicidal. After a close relationship ends, they urgently seek another relationship as a source of care and support. These behaviors rise from the perception that they can't function adequately without others. They crave attention to their complaints. The complaints can be simple or complex in nature, such as their overall lifestyle, social relationships, meaning in life, or medical problems. Overly sensitive to disapproval, people with dependent personality often feel helpless and depressed. They belittle their own abilities and are racked with self-doubt. They take criticism and disapproval as proof that they are worthless. They are likely to avoid positions of responsibility, such as a manager of any kind of position. If their job requires independent initiative, they may suffer occupational impairments or not work at all. Initially, the DSM was proposing passive-aggressive personality traits as a diagnosis under personality disorders. However, the diagnosis was not felt to be fully developed at that time of the publication of the newest DSM. It is helpful, though, for nurses and others to be aware of these traits because working with people who have passive-aggressive traits can be very confusing and disruptive to others. People with passive-aggressive personality traits are chronically irritable and unjustifiably blame others. They are verbally abusive, hostile, and manipulative, and their interpersonal relationships are usually marked by ambivalence and conflict. They resent being asked to do anything for anyone else, either in work or in social situations, and their key traits are negativity and obstructiveness. Their demeanor is usually sullen, and their work is often characterized by procrastination and inefficiency. People with passive-aggressive behavioral traits are more likely to express their negative or hostile feelings indirectly. Although they may openly agree to another's demands or requests, they rarely complete the demand. In fact, the actions of people with passive-aggressive personality are usually the opposite of their promises. Therefore, a person with passive-aggressive traits often disrupts or sabotages other people's projects or plans. Dealing with people that have passive-aggressive traits is usually very difficult. Psychologists have categorized defense mechanisms based upon how primitive they are. The more primitive a defense mechanism, the less effective it works for a person over the long term. However, more primitive defense mechanisms are usually very effective short term, and hence are favored by many people and children, especially when such primitive defense mechanisms are first learned. Adults who don't learn better ways of coping with stress or traumatic events in their lives will often resort to the primitive defense mechanisms as well. People with personality disorders often exhibit outrageous and troublesome behaviors because they are unable to use higher defense mechanisms to modulate painful feelings and to channel needs or aggression into creative outlets. Ambivalence is poorly tolerated, and impulse control is dismal. The most common primitive defense mechanisms include denial, regression, acting out, dissociation, compartmentalization, projection, and reaction formation. Normal people, or at least those who live full and satisfying lives amid the inevitable personal crises and challenging circumstances that naturally constitute life, have at their disposal a variety of higher level defense mechanisms that they use to help them get through such events and eventually continue with their lives. The ego weakness of people with personality disorders relies on more immature or primitive defenses such as splitting, dissociation, and psychotic thinking. Assess for suicidal or homicidal thoughts. If these are present, the patient will need immediate attention. Also determine whether the patient has a medical disorder or another psychiatric disorder that may be responsible for the symptoms, especially something like substance use disorder. View the assessment of personality functioning from within the person's ethnic, cultural, and social background. Ascertain whether the patient experienced a recent loss, especially someone that might be important to them, such as a parent. Personality disorders are often exacerbated after the loss of a significant supporting person or as the result of a disruptive social situation. Evaluate for a change in personality, or especially in middle adulthood or later, which signals the need for a thorough medical workup or assessment from unrecognized substance use disorder. And lastly, be aware of the strong negative emotions that these patients may evoke in you. Finding an approach for helping patients with personality disorders who have overwhelming needs can be daunting for healthcare workers. The intense feelings evoked in the nurse or clinician often mirror the feelings being experienced by the patient. Healthcare workers may feel confused, helpless, angry, and frustrated. These patients are often hostile, calling the nurse inadequate or incompetent. They are abusive of authority and are often successful in using splitting behaviors with the staff. Praising or disparaging the nurse to peers in such a way that the peers begin to react negatively toward each other. Usually, this is the patient's attempt to defend against his or her own feelings of frustration and powerlessness, but when staff are split, the result is often substantial conflict within the treatment team. Untrained and unsupported staff may easily regress or become vengeful in response to a difficult patient's sense of entitlement, manipulativeness, dependency, ingratitude, impulsivity, and rage. Frequent communication among staff and continuous availability of supervision and support are vital in times when the behaviors of these patients start to affect the confidence, feelings, behaviors, and effectiveness of staff members. Nurses and other healthcare workers should practice self-health management. This includes acknowledging and accepting their own emotional responses and attempting to ensure personal well-being. A lack of internal control leads to manipulative behaviors such as lying, cheating, conning, and flattering. To protect the rights of others, external controls must be consistently maintained until the patient is able to behave appropriately. Patients manipulate and control staff members in various ways. By keeping staff members off balance or fighting among themselves, the person with an antisocial personality disorder is left to operate as he or she pleases. It is often difficult to create a therapeutic relationship with patients that have personality disorders. Because most have experienced a series of interrupted therapeutic alliances, their suspiciousness, aloofness, and hostility can be a setup for failure. The guarded and secretive style of many of these patients tend to produce an atmosphere of combativeness. When patients blame and attack others, the nurse needs to understand the context of their complaints. These attacks develop from feelings of threatenedness, and the more intense the complaints, the greater the fear of potential harm or loss. Lacking the ability to trust, patients require a sense of control over what is happening to them. Giving them choices, whether to come to a clinic appointment in the morning or afternoon, for example, may enhance compliance with treatment. Because these individuals are hypersensitive to criticism, yet have no strong sense of autonomy, the most effective teaching of new behaviors builds on their own existing skills. When people with personality disorders exhibit fantasies that attribute to malevolent intentions to the nurse or to others, it is important to orient them to reality. They need to know that even though they have insulted or threatened their caregiver, they will still be helped and protected from being hurt. Several psychotherapies have been shown to be effective in treating personality disorders, although they are lengthy and expensive. Psychodynamic psychotherapy helps patients recognize their responsibility in the existence of turmoil in their lives and learn healthier ways of reacting to other people and problems. Individual, family, and group therapy all can be helpful. Cognitive behavioral therapy helps people become aware of their thought processes so that they can recognize how they draw faulty conclusions. The focus is then on reframing one's faulty thinking into a rational and realistic way of thinking about the world. Behavioral techniques include social skills training and assertiveness training, in helping patients learn more effective ways to deal with their feelings, frustrations, and interpersonal issues. Another approach to cognitive behavioral therapy, which was developed for the parasuicidal individual with borderline personality disorder, is dialectical behavior therapy. Some target behaviors include decreasing life-threatening suicidal behaviors, decreasing therapy interfering behaviors, decreasing quality of life interfering behaviors, and increasing behavioral skills. Second-generation atypical antipsychotics can be helpful for borderline patients that are psychotic under stress. Depression is highly comorbid in these patients. Therefore, the SSRIs, trazodone and Effexor, are good choices because they are the least toxic in overdose. The SSRIs can also help borderline patients who have comorbid panic attacks. Tegretol is used to help target impulsivity, uncontrolled behaviors, and self-harm that has been useful. Some people with antisocial behavior have problems with anger and acting out. Lithium, anticonvulsants, or SSRIs may be helpful to minimize aggression. Anticonvulsants may be used with other personality disorders, as well as to help curb impulsive and aggressive behaviors. People with schizotypal personality disorder, although they rarely voluntarily seek treatment, may be helped with low-dose antipsychotic medications, which help improve anxiety and psychosis-like features associated with this disorder. Obsessive-compulsive personality is often helped with anafranil. This is a tricyclic antidepressant. And SSRIs are also used to improve obsessional thinking and comorbid depression.